relatively predictable manner from one lymph node group to continuous lymph node. That means it's really progressive, highly treatable with high cure rates, but it's really progressive. Non-Hodgkin lymphoma, a diverse group of blood cancer. We can over 60 subtypes, like follicular lymphoma or whatever. We can Google it after the session and give you topics about it. Arises in B cells, T cells, and or NK cells. Like we said, the Hodgkin lymphoma is progressive but highly treatable. The non-Hodgkin lymphoma spreads unpredictably through the lymphatic network and bloodstream, can be slow growing or aggressive. Because in Hodgkin lymphoma, we know this, the lymph node that is infected, another lymph node will be infected. But in non-Hodgkin lymphoma, we don't know where the cancer will go. And this is why it's really aggressive and dangerous. Secondly, we have chronic lymphocytic leukemia or small lymphocytic lymphoma. This is a cancer of mature B cell or B lymphocytes that affects both the bone marrow and blood, and the lymphatic tissue nodules, often considered a slow-growing lymphoma variant. And I don't think you will see it in many patients, but you have to know this name and this cancer, chronic lymphocytic leukemia. And now we will talk about primary lymphatic vascular cancers, and this is rare, but we have to know it because it's really, really dangerous. We have lymphangiosarcoma. As we know, this lymphangium is the most important functional pumping units in the lymphatic system. And now, what happens if we have lymphangiosarcoma? It's a real highly aggressive malignant tumor arising from the endothelial cells of lymphatic vessels. As we said, the endothelial cells and muscles that can move the lymphatic fluid. Now we have cancer. Classically develops as a long-term complication of severe chronic lymphedema. And this is, you have to remember, this is rare. This is rare. The chronic lymphedema doesn't mean you will find lymphangiosarcoma. This is rare. And then we have Kaposi sarcoma. This is a vascular cancer involving endothelial cells of lymphatics and blood vessels, strongly linked to HHV9. This is human hypervirus 8 infection and immunosuppression. This sarcoma really, really harmed the body and vascular system, regardless arterial or venous or lymphatic system. And don't forget, this cancer is rare for the lymphatic vascular cancers. You have to know it, because if I don't think I will let you, if you met one patient of them, you don't know how to deal with him or what caused the lymphatic edema for him. Now, we will move to the cancer associated with secondary lymphedema. Piece of cake. This is more than easy from primary cancers. Because here we have our famous actor here, breast cancer, the most common cause in developed nations, our nations in Africa. So this is our responsibility to focus on breast cancer and make sure the other cancers, but breast cancers, because we have a lot of them in Africa. The breast cancer triggers axillary lymph nodes dissection with sentinel lymph node biopsy and radiation therapy to the axilla. That's why the lymphatic edema will start, because if I do radiotherapy, the connection between axillary and axillary lymph nodes anastomosis will be interrupted by radiation therapy. If I did a radical mastectomy, that means I moved lymph nodes, so the circulation will be interrupted. So the manifestations for breast cancer is upper extremity lymphatic edema, chest wall or breast edema. So in breast cancer, I expect to see edema where? In upper extremities or in breast or in chest wall. That's why I have to distribute every manifestation and manage every sign with them individually. Okay? And with breast cancer, we can see axillary web syndrome, because the lymph fluid have coagulant factors like blood. After meanwhile of lymph node absence after surgery, we find there is a coagulation happens in lymph vessel, and it's like cord the court can limit our motion. This court, these two schools think about it. One school said, stop it. There is no matter what happens after this. And another school, no, left it like how it exists. Because we can do some mobilization to the court, the coagulation, what happens may subside, but don't pop it. In my thoughts, we have to move it or mobilize it, don't pop it, because if we pop it, it puts patients in high risk of lymphatic edema. May the patient remove the lymph nodes, don't have now lymphatic edema, and only have axillary syndrome. So I saw the lymphatic axillary syndrome. Oh, I remember Dr. Yusuf said, pop it. No, don't pop it, because it puts patients in high risk of developing lymphatic edema. And now, gynecological cancers like uterine or endometrial, cervical, ovarian, and valvular cancers. That triggers pelvic para-aortic lymphadenectomy and pelvis radiation. All of these ways can trigger lymphatic circulation, like we said, and like already we saved our information that interruption of lymphatic system will start after radiotherapy or interruption of circulation, lymphadenectomy, like I remove lymph nodes. So the circulation will interrupt at the end and the lymphedema will develop. That manifests unilateral or bilateral extremities, because I don't know if the patient is removed bilateral in lymph nodes or only the radiotherapy affected the connection between lymph nodes, and now the lymphedema will start. And also can develop midline or pubic edema. And this is very, very, very advanced to manage, because this type of edema, it's really hard the patient's lifestyle. Then we have melanoma and skin cancers. That triggers wide localization with regional lymph nodes. With regional lymph nodes section, like inguinal, axillary, or cervical, depending on the tumor location. Manifestates that our limb or head neck lymphedema, because it's cervical, I will move here, so the edema will be exist in face or head. Corresponding to the dissected nodal basin. That means I have melanoma or skin cancer, whatever way. That's the place where the melanoma exists or the skin cancer exists. The oncologist will deal with it. Whatever with radiotherapy or surgery or chemotherapy, all of this treatment modalities will interrupt the lymphatic system in some place, and the nearest organ or the nearest limb will be affected. If I have here, this limb will be affected. If I have lower extremities, the lower extremities will be affected. And now we have urological cancers like prostatic cancer, bladder, renal, and testicular cancers. What triggers the lymphatic system? Radical surgery with pelvic inguinal lymph node removal and radiotherapy. As we said for the fourth time, anything interrupts the lymphatic circulation develops lymphatic edema and manifestates the lower extremity and genital lymphatic edema. And now we have head and neck cancers like oral cavity, paropharyngeal, laryngeal, and thyroid cancer. What triggers the lymphatic system? Neck dissection, radical or modified, and external beam radiation therapy. What is this manifestates? Manifestates facial, cervical, intermucosal lymphatic edema. And this is dangerous because it may close the airways. So it's also really advanced, but you have to know it, because if you meet any patient, you have to spread awareness to him. And now we have sarcomas and soft tissue malignancies. How it triggers the lymphatic system? By extensive surgical resection in extremities combined with adjuvant radiation. This is manifestates localized or distal limb lymphatic edema, because it's sarcomas and soft tissue malignancies. So, after we talk about all types of cancers that may develop secondary lymphatic edema. What is the key pathophysiological mechanism that happens? Any surgical excision of regional lymph nodes, scarring from surgery, that's closed watersheds, where we talked about it before, or radiation-induced fibrosis, impairs normal lymphatic drainage pathway. That's leading to chronic high protein fluid accumulation in the interstitial space. As we said, an interruption develops lymphatic edema. So this is the key pathophysiological mechanism we are talking about today. How to detect this sign early? How can I know how many patients at risk after surgery or radiotherapy or whatever? Now I can see this is why. Hello? Can you hear me?
Yes, we can.
Okay. Now we move to early detection. Early detection means we can catch patient in reversible stage. Like we said, stage 0 and 1. Catching lymphedema at stage 0 or stage 1, this is really, really important. Because when fluid accumulation is mostly protein-rich fluid, rather than fibrotic tissue, like in stage 3 or 4. 3 or 4 or 1 or 2 or 3? 2 or 3. But then fibrotic tissue yields the highest success rate for complete decongestive therapy and prevents long-term tissue changes. So now we know the anatomy, physiology, cancers, and pathophysiology of the lymphatic system. What is our role as a physiotherapists with them? Let's talk about our golden rule in physiotherapy. But before we talk, we have to talk about prevalence in Africa. According to World Health Organization, I don't know why the screen is not moving slides. Yes. Prevalence of lymphatic edema secondary to cancers. We have studies across low and middle income countries, including African nations. Reports an average arm lymphedema prevalence for breast cancer patients 27% to 39% following breast cancer treatment, compared to 50 to 20% in high-income countries. So our culture or our people needs us because they are in high risk for lymphatic edema, so early detection is our responsibility. How we will help them? By complete decongestive therapy, or our rule in physiotherapy using manual lymphatic drainage, skin care, compression therapy, exercise, and added recently self-management. Again, what is our rule? Complete decongestive therapy using 5 steps. First, manual lymphatic drainage using the anchoring filaments, as we said before, the ones attached to the skin and lymphatic vessels to create the osmotic acoustic pressure so they can suction the fluid in interstitial space. Secondly, skin care, because if we have ulcers like the patient in the first of slides, we will return to the results again. But if we have ulcers or whatever, we have to take care of this skin because we don't like to catch any microbacteria that will make after them the cellulitis, which is life-threatening condition for patients. Then we use compression therapy. Compression therapy that creates a gradual compression from distal to proximal, which helps the lymphatic circulation to drain. We will talk about it, but let's move to another step. This is exercise. And now, this is a question. We said the muscle demand or contract and release increases the arterial demand. That means high filtration rate. And we said the lymphatic system has a mechanical failure. How the lymphatic system will drain or catch the fluids if he has more filtration rate. How exercise help with patients with lymphatic edema? Now I will stop talking and I will wait someone to answer.
Okay, I can see someone is raising his hand. Abdullah, you can unmute. Read one, Abdullah, Abdul Fattah. can unmute your mic.
Thank you very much. Dr. Rahman can share with us why we use exercise.
Because when you use exercise is going to help with venous return, thereby reducing the amount of fluid that will go into the lymphatic system. That's what I think, because of the muscle venous pump.
Okay, but we said that the lymphatic system now, the lymphatic motility or the lymphatic motion can't compensate with the edema. So more muscle contraction release, that means arterial demand, high filtration, more fluids in interstitial space. So how exercise really helps lymphatic patients or when to use it? Dr. Abdurrahman?
We do exercise under compression therapy. That's prevent the lymphedema to become more and more. That's it.
That's a really great answer because that's right, totally. We use exercise under compression because the muscle power, again, it's the compression power that helps the lymphatic system to drain the fluids up to the lymph nodes. And this is why and when we use exercise. Thank you, Dr. Rahman, for this great answer.
Welcome, Dr.
And now we move to self-management. We have to give knowledge to patients to self-management.
I think someone was raising up her hand. Sarah, the question.
I can't hear you clearly, so please.
I think someone was raising up her hand. Sarah, or you don't have any other question again?
You need me to repeat the question or the answer?
I think she is saying there is someone raised his hand.
Oh, someone raised his hand? Who is it?
Yeah, but
yes. He already gave us his answer, and really thank for him for his answer.
Okay, so you can go on, sir.
The sound is better now. I can hear you clearly now. Thank you, Dr. Rahman and Dr. Edward, for the answer. And now we move to self-management. Why self-management is important with lymphedema patients? Because it's not about business only. Greedy people, the lymphatic edema patients must come to the clinic to do self-management again and again. But self-management at home, how to manage risk, is really, really important to spread knowledge to the patient. After we achieve the congestive phase and we decrease edema, now we have to reach maintenance phase. Maintenance phase, that means I have huge edematous tissue. Now the edema is decreased and I reach plateau. What is plateau? This is the no way this limb will decrease anymore. When I reach this point, I start to use compression garments, not bandage, and use exercise, as Dr. Rahman said, to help lymphatic circulation and also. And I have to take care of skin care. I don't have any skin crack or something may develop cellulitis. I'm used to do my lymphatic drainage, which is help the lymphatic system and assist the patient to prevent develop any other lymphatic edema. The slides is off now, right? May you excuse me for technical support because I'm presenting from 3 devices. So give me 1 moment. The internet, okay. Where's Dr. Adam? Is Dr. Adam here?
Yes, I'm here.
We will wait for a second to manage this technical support issue, and so we can manage it. I want to thank you for your effort for 1 year to collect all people from Africa. This is really, really great thing you are doing with all doctors and team. And I'm really, really waiting for seeing you in Egypt, or I'm coming to you to Nigeria.
Thank you so much. I can't wait to.
It's my dearest friend. We really, really grateful for this friendship. And now let's continue. Anyone feels tired? You feel tired, Dr. Adamo?
No, I'm not tired.
Adi,
there's someone want to think. Who is one to think? Yes, Ngozi?
No, I didn't hear what you said.
What?
He's asking if you want to speak or say something. That's what he's asking. Okay, no, I'm waiting till the end of the lecture so that I can ask my questions.
We have technical issue of presenting the slides, so I'm working on it now. So let's continue. Our complete decongestive therapy consists of, again, of manual lymphatic drainage, compression therapy, exercise, and self-management. Then that's why we use compression therapy. In compression therapy, we use short stretch bandage, which have characters of high working pressure and low resting pressure. So when I do compression therapy for patients, I will not squeeze arterial circulation during resting. That's why we use special bandages for lymphedema patients. And the manual lymphatic drainage is doing on bare skin, and we don't use any oil or lubricant during session because we have to move the skin using alkaline filament function to drainage fluids. And now we have to know our scope. In lymphedema, what's our scope? We have a vascular scope, oncology, nephrology, pediatric, dermatology, and neurology, sports medicine, and more. Because the lymphatic system is drained with excessive fluid, regardless of the cause, and may develop mechanical failure for any cause of this scope. You have to know that lymphatic edema differentiates totally from edema. And now we will back to the results of our case today, which have skin cracking caused by edema, and the patients have lymphedema that's caused by chronic venous insufficiency. As you see, we managed to treat the ulcer with only compression therapy and the skin ulcer care. And the edema now is subsiding. In this case, treated by Dr. Yusuf Hassan May and Dr. Ghada and Dr. Amani Abdelkrim. And now, the second case for dry lymphatic edema. This patient has atresia of lymphatic system. The initial lymphatic vessels does not exist. This what we used with him and CDT only, and now we can see this the limb is really decongested, and we reach the maintenance phase. After we reach plateau, there is no more decrease in size. We start using compression garment. This case is treated by our prof pioneer lymphedema medalist Dr. Michel Fathi. This is a filariasis and really famous in Africa, especially in Nigeria. That's case caused by microfilaria system. We'll talk about it in the lecture, I think. But how can thoroughly this patient? This is the congest phase, and we reach into the maintenance phase. And this is a case with lymphadenectomy. We remove lymph nodes after lymphoma, Hodgkin lymphoma. As we see, the edema started proximally, then moved to distal. This is against our rule in mechanical failure. That's why we suspected this patient had lymphoma. After we referred him to the oncologist applied lymphadenectomy. Then we started to decongest his limb, reaching the maintenance phase using compression garments. And this is liposarcoma surgery case treated with honor of Dr. Abdurrahman Mahmoud. He is the most skilled doctors here in Egypt. This case, after surgery, the lymphatic circulation interrupted, and he applied CDT only, and now you can see the limb is really decongested, and the limitous tissue now is really absent. And now we have to move to the misdiagnosis. Don't misdiagnose the lymphatic circulation with arterial insufficiency or renal failure, liver failure, or abscess. And don't work with patients who have active cellulitis, because if you use manual lymphatic or conversion therapy, you will move cellulitis from space to another. That's so spread cellulitis and makes patient's life more dangerous. Now, we have lymphedema. This will be our next topic with Dr. Adamo. We will plan for it, but you have to know this is not lymphatic edema, and this is not cellulite. This is lymphedema. So, in the end of maintenance phase, we use compression garments. The compression garments have two theories. One, called Valcrum, and another called flat-knitted compression garment. The normal compression garment we can find in our countries is round-knitted. It's made for chronic venous insufficiency or varicose veins. That's when the valves can't work sufficiently. Then we apply compression garment. Now the valve is near and can work. This is round-knitted. It's made around size. But in flat-knitted or lymphedema patients, we use compression garments with flat knitted. It's made in longitudinal lines. That's when we put to the skin, the water can drainage between the lines we made. So it's custom made. We only require it for the lymphedema patients. And this Velcro or Silk Aid compression garment we use for the patients we can't find appropriate size for him after the congestive phase. And also we can use it as a reduction kit, but it's not good as the compression bandage. And now we have open floor for questions. Yes, please, Dr. Sarah.
يا دكتور، كان في كيس دلوقتي انت حضرتك عرفتها، قلت ان هي بدأت الإديمة عندها من بروكسيمال تو ديستال. مش هو لما يكون عندنا الإديمة من بروكسيمال تو ديستال المفروض ان انا ما بشتغلش، لان هي تبقى حالة مالجنانت، يعني الموضوع بيكون صعب معاها ولا ايه؟
Okay, Dr. Sarah is asking about this case. She said if we have an edema starts proximal to distal, this is not our case. Like we said before, it's systemic failure, not our rule to work with it. And this is right, because in this case, we didn't work with this patient. We referred it to the oncologist. And after oncologist removed the lymph nodes which was infected with cancer, we started to apply CDT using the inguinal anastomosis. After this, we applied compression bandage. We didn't work with patient during cancer. After surgery and after the circulation, the lymphatic circulation interrupted, we started to work with it. Okay?
Okay, تمام.
Dr. Magosi?
Hello?
Yes.
Okay, thank you, Dr. Hassan. I have some questions to ask at this point. One, in case of metastasis,
yes,
when this cancer has spread to other organs, do you still encourage manual lymphatic drainage? Then
I think it's yes, because okay. Complete your answers first, questions first, so I can answer it all.
Okay. Then two, the third stage of lymphedema, when fibrosis has already set in, do lymphedema also does it respond to manual lymphatic drainage and compression therapy?
Okay. Okay. First question was if we have metastasis, can we use manual lymphatic drainage or no? After we discussed with our oncologists in our conferences for 2 years before, we reached that we can use manual lymphatic drainage if we have metastasis, because the lymphatic system will not carry cancer cells and move with it. But blood can. not the lymphatic system. So if I'm helping the patient for the quality of life using manual lymphatic drainage and compression, there is no high risk for increasing metastasis. What's happened? And now for the second question, I forgot it. No.
The second question, third stage of lymphedema. Stage of lymphedema.
I remember the question. Okay, thank you, Dr. Negozi. When we are talking about fibrosis, lymphatic edema, or fibrosis, we are talking about collagen type 2. Collagen type 2, when it exists in our body, that's be like gel-like heart. It's not our tissue, it's gel-like heart. When we move the skin repetitively, one more again and again, the fibrosis starts to collapse and the collagen line starts to break down. So the manual lymphatic drainage helps in collagen breakdown in fibrosis stage 1 and 2. And there is more tip for you, Dr. Negozi. When we apply conversion therapy for fibrotic tissue or fibrotic edematous patients, we use something called Mobiderm. Mobiderm is at small cubes. We put it in the skin of the patient. When we apply conversion therapy, it breaks down the collagen. I think I can give you photo of it, so you can imagine probably with me. That will be there. Yes, we have one here. So, the movie there is now what you see, okay?
Okay.
These tubes, after applying conversion bandage, after applying conversion bandage, and we have these cubes on the skin, so the cubes will pressure in different places. This will break down the fibrosis. And the next time when patient comes to my clinic and I deconverse him, and next time I use Mobiderm, I would never put it in the same place because I can't determine what is the places I put it in last time. This theory or this mechanism of compression helps in break down fibrosis along with manual lymphatic drainage. But believe me, manual lymphatic drainage is really, really helping with patients who have fibrotic tissue.
Okay. Are you saying compression should come first before the manual lymphatic drainage in a fibrotic case?
No, I have to work in parallel between them. I have to apply manual lymphatic drainage for appropriate time to break down collagen, and remaining the breakdown when I let the patient go to home by the Mobiderm. The two must be used in parallel at the same time.
Okay, at the same time.
Yes.
Okay. Well, okay. Most of those supplies, we hardly get them here in Nigeria.
We also here in Egypt, we have hard way to apply, but believe me, Mobiderm is really, really easy material to start make it in Nigeria because it's only, I think, it's matte, not something hard to make. Here in Egypt, we started to make it here, and now with lower price and availability more. If you want me to give Animal or the President of Nigerian Physiotherapy Association the number of our distributor here in Egypt, that will may help you in buying all tools you need.
Okay, that will be fine. That will be fine because we don't have access to it here.
Sure,
but just improvising.
If you could be able make it in your country by your hands, that will help patients make it really lower in cost, and the theory or the way you can make it not hard.
Okay.
So we still have our open floor for questions from our 30 candidates.
Can I still ask more questions, or have the lecture ended? Have the lecture ended?
Okay.
Okay, I want to ask, how do one become a certified lymphedema therapist?
Okay, as you said in the first lecture, we have grading of courses as Golden Force School. That starts with introductory certificates. We have to come to your country because hand skills can be delivered online. So we start with the introductory course for 3 days of theoretical and practical work. Then after 2 months and 3 months, you can apply to the certificate of lymphedema therapist. You have 2 months of theoretical study, then more than 9 days practical. After this, you can call yourself certified lymphedema therapist. And after 1 year of practicing, you apply to the advanced certified lymphedema therapist because you will see many cases and have a lot of questions. Here we can help you to advance your hand skills and theoretical parts and make you advanced lymphedema therapist.
Okay. Please, are there sponsors? Are there companies or that sponsor this training? Because I'm interested.
So please contact Dr. Adamo and me after this session, and we can give you all you need about this point.
Okay.
I'm hoping to see you all CLTs and helping people all around Africa because this is our nation, our countries.
I didn't hear you.
You can call Dr. Adamo after session and call me, and I'll give you all details about this point.
All right. Thank you.
Thank you. I hope seeing you all CLTs. And now, if we have any questions?
Okay, sorry, I wanted to ask, I didn't get what you said last. Did you say that we should contact you for further information about the training?
Please, there's noise. Your mic, can you please write it down in chat?
There is no noise in my background. Can you hear me now?
Yes, I can hear you now.
Okay, I said the last statement, your last answer to the last speaker, you said we should contact you for the training.
Yes, because we have in Adult Nephrology School our programs for this.
Okay, so through the WhatsApp, I don't know how do we get your contact?
If you were patient for the end of session, you would see this contact, okay? But because now we are in the open floor space, after we end our questions, I will give you all details about this point.
All right, now, thank you.
If we don't have any questions, let's please end this session.
Okay, any other questions before we close for today?
Okay, I think we don't have questions. So I'm really happy to be with you today. I thank you for being with me, and I am really interested to hear from you after this session. Anyone have any case, please contact me. Anyone have any question, you can find me online, any platform you need. And if you want any source to study from it, I can send it to you. So please don't hesitate to contact me. I'm really glad to be with you today. Thank you.
Okay, thank you, Dr. Yusuf. We'll be calling on Peter Adamo to help us with the closing remark. And please, we should drop our email address so that the slides can be emailed to us after this section. So you can drop it on the message.
Okay.
And Pete Wakura will help us with his contact if you want to be added to our WhatsApp group, Physio Africa Knowledge Hub. If you want to remember, you can reach out to Pete Wakura on the message box so that you can be added. Thank you very much. Sadamu.
Please wait a second so we can turn the photo together. Say bye. Thank you very much for your hospitality and waiting to see you in another episode.